one, which cause disease that can be very, very severe and cause mostly respiratory failure, adult respiratory distress syndrome, as well as asymptomatic disease. Just basically, these viruses survive on surfaces and they exist in mucus, so they're spread from droplets and direct contact mostly. Even though they can hang in air, they're usually not spread by the so-called airborne route like measles and tuberculosis. And they're easily inactivated by alcohol, by dilute hydrogen peroxide, or bleach, dilute bleach. So cleansing surfaces that a person has contact with is very, very important. Now, for this virus, there's evidence that it began to infect humans in the Wuhan area of central China as early as October and November of last year. It's very closely related to a coronavirus in the rat population in that area, but direct contact with bats probably didn't cause this because the bats have been in hibernation during the winter, and they were not present out and about or being used or shown in China at that time. So there's probably another intermediate animal host that helps transmit the virus or help transmit the virus to humans. It's not snakes, because coronaviruses don't infect reptiles as far as we know. And the so-called pangolin connection appears to be a moderately different virus, and so it's probably not related to pangolins. We don't yet know what the amplifying host or the transmitting host was. The seafood market in Wuhan was not the source of this epidemic. Now, SARS came and went very quickly, probably because it was not easily transmitted from person to person. Now, this virus is basically the nightmare scenario that we worried about with SARS, because when there's no social isolation and people are freely mixing, this virus appears to spread to between 2 and 3 people for every infection there is. And so you've set up an explosive situation for epidemic, whereas we've seen it basically doubles every, maybe every 3 to 6 days, 7 days, we've seen massive doubling. After exposure, the infection or the symptoms usually begin anywhere between 2 and 12 days, but usually about 5 days after infection. And there's a high viral count in the nose, upper respiratory area, so that cough, droplet, touching, even before a person has symptoms, will transmit the virus. Now, a lot of people have very few symptoms, especially initially, or very mild cold-like symptoms. It's more likely to be children. The initial symptoms can be cough, runny nose, especially initially. Now, we don't know if most people become symptomatic. There's sort of lack of clarity. Some people think that most people will become symptomatic. Others have commented that there's mostly asymptomatic infection early. We just don't know how much of this is relevant. The people who do have symptoms, however, often report the abrupt onset of fever, which is a temperature over 100.5, 100.6, or 38 degrees, associated with just extreme fatigue, cough, and some feeling short of breath, even without low oxygen. The other symptoms can include diarrhea in about 5 to 8% of people, headache, sore throat. In other words, it's very similar to symptoms of influenza, although the people who've been infected say it feels different. It feels more serious, something unlike what they've experienced before. In most people, this improves over 4 to 6 days, and no treatment is necessary. But the virus may continue to be present in sputum, mucus, and in stool, even for about 12 to 14 days, longer in people who've been sicker or in people who've been treated with prednisone or other immunosuppressive agents. It's likely but not proven that these people who have recovered from COVID-19 infections are immune. We don't know yet. It hasn't been shown. There have been a few reports of so-called recurrent infection, but they really haven't been borne out. To prevent transmission for healthcare workers, for usual patient care, what most of us have been recommending is droplet precaution. In other words, very careful hand washing before and after touching anything close to the patient or the patient, use of gloves, gown, eye shield, and being very careful about not touching the healthcare worker's face without the hand washing and changing gloves. That includes adjusting the mask. It's hard to do. You have to be very conscious and aware of this. During procedures that spread aerosols, like intubating a patient, bronchoscopy, nebulizer treatments, it's most important to use the maximum protection with N95 masks or the equivalent, PAPRs, to prevent transmission. But these are special situations, and some hospitals actually have intubation teams that are all ready to go with PAPRs and the highest protection gear available. Just to note that travel should be restricted during this outbreak, just because traveling, you have more exposures and opportunities to touch people and transmit the infection. Also, in just the normal population, hand washing is really the most important maneuver you can take, as well as avoiding touching your face. You've heard this again and again. Despite the fact you see lots of people wearing face masks, they can actually make things more dangerous if you touch them. And wearing a face mask all day decreases its ability to prevent transmission of all sorts of things. And as you touch it, you're actually contaminating your hand, you're contaminating the mask. So it really doesn't serve a big importance when you're out and about in your daily life. Now, as far as the epidemiology of this, the first outbreak is usually, besides in a single person and family cluster, you see all these small clusters of susceptible people arise. And because this is a new virus, everyone is susceptible, and these clusters continue to enlarge and spread. You've seen the patterns in the different maps that have been available in the newspapers and online. As you see this enlarge, the small clusters coalesce, and you see an epidemic and pandemic in areas such as northern Italy, and then around the world. And this is an uncontrolled infection on every continent. There are different maneuvers to prevent spread at the different phases of these epidemics. The early cluster phase of spread can usually be controlled with very quick testing, identification of people who are sick, and then tracing all the contacts that these people have had and isolating people, such as in quarantine. Hong Kong, Singapore, Taiwan have been notable that they've been able to control this or suppress the epidemic, although there are always breakthroughs. It's like fighting a fire. There are small fires that are constantly arising and have to be quashed. Vietnam, last I spoke to anybody in Vietnam was just 3 days ago. They had reported about 90 cases at that time. And they're also in that category, at least as far as that goes. Now remember, all this depends on wide testing, which has not generally been available. Once there's a larger community epidemic spread, where you can't identify specific factors like travel or known exposure, you're in a mitigation phase. You isolate people, you tell them how to maintain good hygiene and respiratory etiquette, social distancing and quarantine, such as what our governor here in California and in many of the states in the United States have already promoted. These maneuvers may reduce the total numbers of infected and allow a slower evolution of the epidemic. This is what China has been experiencing, that there's a very slow increase, leveling, and then even decrease in infections. The time course of this phase is usually weeks to months. In areas where the epidemic has waned, they remain at risk for repeated outbreaks as long as there are susceptible persons. I placed a graphic from the internet of these different social responses just for you to see. Now, as far as treatment goes, mild to moderate disease does not require treatment. So 80 to 90% of people need no treatment. They're going to get better, do well, and hopefully become immune. People at higher risk of illness include the elderly, and the risk seems to increase in concert with the age. So people over 80 are at the highest risk. People between 60 and 80 are a little bit less, but at higher risk. People 50 to 60 are at higher risk. People with high blood pressure, heart and lung disease seem to be at higher risk for developing worsening illness. And sometimes this worsening can occur even after an initial phase of improvement. So in people who are at high risk, you want to keep in contact with them. And if there's a sign of worsening, then get them in for evaluation and possibly hospitalization for supportive care. Supportive care means oxygen, fluids, medications to make them more comfortable. Pregnant women do not appear to be at higher risk of severe disease, and although newborns can become infected, they don't seem to have severe disease. Although, remember, severe disease can occasionally occur in just about anyone, no matter what their age. So you have to be alert to anybody who's getting sick. Now, as far as direct treatment, there's no specific treatment that has been tested and found to be effective yet. There are lots of studies going on right now. So nobody, including people in the administration, should be giving recommendations for what to be treated with. For moderate to severe disease, the experimental treatments include antivirals, remdesivir, favipiravir. These are RNA polymerase inhibitors. The anti-malarial quinolines, chloroquine and hydroxychloroquine have gotten a lot of notability recently, and they have very minimal experimental evidence for good. They are somewhat dangerous at high doses, and so so who is treated has to be carefully chosen and monitored for those. And of course, there's been a run on these, so these are in short supply throughout the United States at the present time. Other therapies include anti-cytokine therapies. These are therapies that are designed to blunt a person's immune response, because ironically, it's the inflammation that sometimes can make the infection worse, and that can sort of bring on adult respiratory distress syndrome and respiratory failure. And then there are other treatments, there are antibody treatments, even treating with the serum of people who've already convalesced has been tried or is being tried in China at the present time. The most important treatment principle is good supportive care, oxygen, ventilation, blood pressure control, and prevention of new infections that any sick person can get. Finally, on your public health websites, and I put, for example, in this slide set, the Los Angeles County Public Health Department checklist, just the general care and recommendations for quarantine. And these are available in several languages, not just English and Spanish, but Chinese and Vietnamese and other languages, of how to prevent spread. And once a person is at home quarantine, you take care to avoid exposure to other people. People who with confirmed infection should be provided with these instructions that you can either download or hard copy can be given. And people who are waiting for test results we should presume that they're infectious and they should follow the same instructions. Now remember about testing. A negative test, especially early on, does not prove that a person's not infected. So it's sort of ridiculous to see that the vice president and his wife have tested negative. It's not a final word. So to run out and get tested when you have no symptoms really has little point. If a person has symptoms, they should be tested, and then if positive, they know what kind of isolation and quarantine they should follow. In the absence of testing, if you know you've been exposed, you should follow the same isolation and quarantine, although there are exceptions. With healthcare workers who are in short supply themselves, we recommend that if you've been exposed, a known exposure means that you were not using the recommended protection. You couldn't use it at the time, and you were exposed to someone highly suspected or known to be positive. Monitor yourself. If you become symptomatic, then you should either be tested or use isolation and quarantine. After exposure, if you've known you've been exposed, if you're asymptomatic, you should use a surgical mask and careful hygiene to prevent transmitting this to anyone else before your symptoms develop. We're not sure in total about when to discontinue this isolation. The guidelines are basically 7 days, sometimes 10 days after recovery. Really, you should be guided by your specific doctor who's following you, or public health. In the future, when we have better testing available, we may be guided by who tests negative, and it's 2 consecutive negative tests, at least 24 or 48 hours apart. Again, because late in the disease, people can test false negative. The virus can be present in stool, so of course, very careful hygiene, especially with infected kids who might be shedding the virus in stool, is very, very important. Anyway, that's a thumbnail sketch of this, and please, other people chime in with questions or comments, and let's hear the other presenters.
Well, thank you very much, Jared. And then Dr. Weiss, could you present what you have, and then make comments about the testing, because you're absolutely right. The testing is very confusing. So people are rushing in my office to demand to be tested, and they don't have any of the criteria. You send them to the Orange County Public Health, and the Public Health said, you don't have criteria, you don't get the test. And then they get very adamant about it. And then now that we have the private testing, then we tell them that we could test you, and this is what is going to cost. For example, in Orange County, the LabCorp and Quest have the test, and then you could actually get the test, but we can send the test for them, and if they don't have insurance, then the private pay is $86. People can pay $86 and get the test, but it takes 3-4 days to get the results. So, but then again, like you said, to show, like the president shows, that negative doesn't mean that you're not going to get a positive tomorrow or right the next day, or already by the time you get the test results back. So Dr. Weiss, you want to
okay.
speak up?
I will. Am I on screen? Or at least my slides on. But first, let me mention that I thought that Dr. Spotkov's presentation was extraordinarily comprehensive and excellent. And Jared, if I make any mistakes when I comment about testing and testing prerogatives, feel free to interrupt me. The news is replete with mentions of new rapid turnaround point of care testing that allows test results within a day or 4 hours or 45 minutes. The CDC has recently made a statement that testing in highly impacted areas should now be limited to testing of hospitalized patients and healthcare workers exclusively, partly as a consequence of the fact that the testing swabs have become a supply chain problem.
Right.
There's probably a role for testing in communities that don't think they have any disease from an epidemiologic standpoint. So there are wide parts of the United States that say even though there are reports in all states, they don't believe they have major impact. Their testing may be useful to encourage the governors to start social distancing and home quarantining. I think the test that you're referring to that perhaps people are offering in the community is an antibody test, which is, I think, developed in Korea, which I think probably only has effectiveness when you have known disease and monitoring late in the course of the illness. It's remarkably unreliable for testing early in the disease. Is that right, Jared? Well, he might be muted. Any questions about that, Quynh, or did you want me to mention any more about the testing?
Oh, I think that's pretty thorough. Dr. Quynh Kieu, what do you think?
So, let's go back to my first slide. Thank you.
Sorry, that was correct.
Okay, good. So a couple of things about home care issues in treating patients who think they may have a viral upper respiratory tract infection with systemic symptoms that trigger any underlying illnesses that they have, such as COPD and asthma, probably the two most significant respiratory illnesses, in addition to underlying congestive heart failure, which can get much worse with a COVID infection, a coronavirus infection. The issues there are, while steroids are discouraged for treatment in the inpatient setting for the treatment of the coronavirus infection itself, steroids still play a useful role in treating the symptoms of asthma and COPD. And it's not recommended that they be completely avoided if it's part of standard care of those underlying diseases. One other important thing for maintaining care at home is to making sure patients who have underlying heart and lung disease have adequate supplies of their medications at home. This may be difficult from a financial standpoint, but for those who have access to mail order pharmacies, having a supply of inhalers and routine medications that you take at home, in addition to the treatments for standard care of cold and flu, are very useful to have. That decreases the amount of time people will have to have access to a healthcare provider to get refills of prescriptions. And some medications may be also caught up in the supply chain issues. Many inhalers are made outside of the United States. And many base chemicals for the development of pharmaceuticals that are made in the United States are actually produced in China and India. And a lot of these drugs have been embargoed. Let me quickly talk about the routine care of viral pneumonia and whether or not there are any specific variations with regards to the coronavirus infection. Dr. Spotkov actually did a good part in talking about this. Just stay on the first slide. I'm still on the first slide. Right, the treatment for viral pneumonias, standard supportive care. As with many pneumonias, oxygen when needed, respiratory treatments, those that minimize the development of aerosols from the patient. So standard aerosol nebulization treatments for medicines like albuterol or Atrovent should probably be avoided to minimize healthcare worker exposure, and the use of meter dose inhalers, the little puffers that people carry around, decreases the risk of aerosolization in the room. As a pulmonary critical care physician, this is a watchword. We never treat based on what's published in CNN or on a daily presidential briefing. Dr. Fauci pointed out quite rightly that anything that's reported as an anecdote or a first-person report of benefit or something generated out of a medical center where none of the data has been published is essentially unproven. A case in point is the use of the anti-malarial drugs hydroxychloroquine and chloroquine, with or without the addition of an antibiotic called azithromycin. Not even sure why that was even studied, except it's said to decrease inflammation in the lung associated with pneumonia. None of this data has been published. There are good uses for hydroxychloroquine in patients with rheumatoid arthritis, and already the supply chain for hydroxychloroquine has become clogged. So patients who have a proven benefit for use can't get it, and it's being used, I hope you all understand the term, willy-nilly. It's given because it's thought to be short-term, cheap, and safe to use, except no one knows if it's beneficial. It is subject to some randomized controlled trials, the data of which won't be available for some months probably. We'll get down to my fifth bullet point. In patients in the hospital receiving supportive care and supplemental oxygen, there's a point at which they'll fail to be able to breathe on their own. The things that have been used to treat patients to avoid the time to getting a tube down the throat, called intubation, are things called heated high flow oxygen and non-invasive ventilation, or BiPAP for short. Those two things, high flow oxygen and BiPAP, have a huge aerosol risk in the room and increase healthcare worker exposure. So if ventilators are available, patients will progress from supplemental oxygen, usually directly to intubation and mechanical ventilation. For a pulmonary critical care physician or an anesthesia critical care physician or any other physician working in the critical care setting, the treatment with mechanical ventilation follows the standard protocols that we use for treating viral pneumonia, acute lung injury, and acute respiratory distress syndrome. The acronym is ARDS. Other things that you may have seen mentioned in the press out of Wuhan and will be used sporadically where available is extracorporeal membrane oxygenation. The acronym is ECMO. That takes the lungs out of the circuit completely and oxygenates and scrubs the blood of carbon dioxide with a machine called a bypass machine. This allows the lungs to recover without having the mechanical effects of inflation and deflation. It takes a lot of pressure to blow up a diseased lung, and there are a lot of potential complications of mechanical ventilation itself. Next bullet point, as Dr. Spotkov mentioned, the role of corticosteroids in treating this particular viral pneumonia is not recommended. And he already went into details about that. Can we skip to the next slide now? And again, I mentioned the exceptions for corticosteroid use are for the treatment of an underlying flare of asthma or chronic obstructive pulmonary disease. Dr. Spotkov mentioned about the use of antibiotics to treat secondary bacterial pneumonias, which were seen as I think reported in the WHO China report in late February was as high as 18 to 20%, probably higher. We also cause pneumonias from our interventions of mechanical ventilation called ventilator-associated pneumonias. So we have to be on guard in the intensive care unit to do everything to avoid ventilator-associated pneumonia. There are some standardly used inhalational drugs into the ventilator circuit which help the circulation of blood and improve oxygenation while patients are on a breathing machine. These include prostacyclines. I won't go into too much detail. These are drugs that are used to treat pulmonary hypertension. And nitric oxide, which has been around for hundreds of years. I say 100 years. It's available in tanks. There are a couple of companies that have just gotten FDA approval to use their particular device to deliver nitric oxide, but this has been done, oh, by the way, at a very high price. Nitric oxide can be made in a backyard chemistry lab, but unfortunately, it's a proprietary drug with some exposure to the generic market, but it remains fairly expensive. I'll talk briefly about imaging studies because this is interesting. This is something when testing became in short supply, CT scanning was used to identify patients early in the course of their disease in China. And the Chinese cohort of radiologists became quite good in correlating the CT scan findings with true disease that was subsequently documented in the hospital. CT scanning's actually shown changes in the lung before the onset of symptoms. So one could say maybe Vice President Pence should have had a CAT scan, not a viral RNA test through a PCR. I'm not suggesting that, but that might have been more useful. The CT scan findings are most severe 9 to 10 days after the onset of symptoms. And that's about the time the patients who are hospitalized, if they were going to need intubation, is when they were transferred to the ICU and put on ventilators. Ultrasound devices, the lung, have been studied, and in places where CT scanning is in short supply, lung ultrasonography may also show the same types of funny shadows that are seen in the lung on the CT scan. This next slide, if you could skip to the next slide. Jared, have you seen this?
I have.
Yes, this is a fascinating slide that came from intensive care unit in Kirkland Hospital. The little QR code at the middle, when scanned, gives the most current version, and I think this is the most current version, 25, which gives a summary of everything that Dr. Spotkov talked about, including some selected images on CT scanning, laboratory imaging, and the hyperlinks are all clickable to get either definitions or source material. I don't think, Jared, you talked about the failure of the dual HIV treatment. Did you mention that? I'm sorry if I missed it.
It was in the protease inhibitor category.
Yeah.
Other HIV protease inhibitors are being looked at, and this isn't the final word, but it's an example of what you mentioned about untested therapies. We're going to learn more about these.
Yeah, and it may be the case we'll learn more about the untested therapies being failures, but what we never worry about, or what's never mentioned in the press, is the potential toxicity of an unproven therapeutic intervention, especially when it deprives other people who can benefit from that intervention. And the talk about azithromycin, which is an antibiotic that is used to modify lung injury and a whole host of infections, bacterial and viral, is become particularly hazardous in the hospital because of the risk of developing electrical storm in the heart, causing cardiac death and irregular heartbeats. So that mention of that drug being used without good thought is bothersome to me. I didn't mention, and Jared, you did refer to the flattening the curve phenomenon, which is to get people into home isolation so the peak infections don't come early and overwhelm the hospital systems. Overwhelming the hospital systems is probably one of the major causes of healthcare worker exposure in China, in Italy, where the hospitals were not prepared for the huge influx of patients that came early. That's that graph at the bottom left corner. That doesn't mean fewer people will get infected, probably. It just means people will get infected over a longer time course of illness, of the disease, which I think when you look at the report from the Imperial College of London, projected a time course of no less than about 18 months. Is that correct, Jared?
Yes, that's correct.
Yeah. So I don't know if we're all going to be in home isolation for 18 months. We may have a brief respite, but I think we have to pay attention to what government leaders, our local and state government leaders, have to say. I think that pretty much ends what I wanted to talk about this morning. Oh, and I'm sorry, I did want to mention something. There is and Dr. Spotkov talked about this, there's always been a divergence for personal protective equipment between the WHO recommendations and the CDC recommendations. The initial CDC recommendations for healthcare workers was that everyone wore an N95 mask or a powered air purifying respirator, those little hoods with oxygen. The WHO reserved recommendations for N95 masks and PAPRs to people who are doing high-risk procedures, and otherwise recommended droplet precautions for their hospital care workers who are not in high-risk settings. This probably reflects good science, but also respects the fact that N95s and PAPRs would soon come into short supply if everyone used them inside the hospital setting. So I don't believe the CDC's recent change in recommending that people wear surgical masks rather than N95s is a step back. It just puts us in line with the rest of the world. Is that correct, Jared?
Yeah, I think Americans tend to view risk in a different fashion. And so we like the concept of zero risk, and there really is no possible zero risk situation. In this setting, I agree that N95, which is in short supply, doesn't give you that much more safety, except in the situations that you mentioned. High aerosolization procedures where the droplets are tiny and stay suspended in air. So yeah, a surgical mask with eye protection really should be adequate in the vast majority of healthcare situations.
Great, thank you so much. Oh, Dr. Quynh Kieu, we can't hear you. Let's see. Sorry.
Can you hear me now?
Yes, we can hear you now.
All right. So Marvin, please comment on the avoidance of NSAIDs, because it came initially out of France, but there is another report which says that that's not validated and it's okay to use the ibuprofen.
Well, in reference to the treatment of fever, both Tylenol or paracetamol and Motrin or other NSAIDs have been popular. Yes, the report out of France suggested that NSAIDs were unsafe. I believe subsequent to that report, many societal guidelines do not prohibit the use of NSAIDs. The reason to avoid NSAIDs is in patients who are elderly or have pre-existing kidney or liver disease, where it's probably wise to avoid in any circumstance in an illness with fever. And certainly NSAIDs are used much less commonly in the hospital, exactly for that reason. So we're referring mostly to outpatient use of NSAIDs to control fever. And if in general, the recommendations currently are if your health is good and you don't have any underlying kidney or liver disease, NSAIDs do not have to be off the table for treatment of fever. I think that's the current standing for NSAIDs. Let me mention a couple of other things that have come up related to normal drugs that have been taken. And these are drugs called ACE inhibitors and angiotensin receptor blocking agents. And this is an intriguing thing because the coronavirus, the CoV-2 SARS coronavirus, has an intriguing ability to attach to the many cells in the body, including the alveolar type 2 cells in the lung and those that line the airways through receptors called ACE2, or angiotensin converting enzyme 2 receptors. Now, it's very confusing what this means. Men are more affected with infections. Women have higher levels of ACE receptors in their body. ACE inhibitors and ARB drugs can potentially increase the number of ACE receptors in the respiratory tree and throughout the body. And in Italy, the biggest comorbidity associated with death in the intensive care unit was the presence of hypertension alone. ACE inhibitors and ARBs are commonly used in developed countries for the treatment of hypertension as first-line agents, and that includes Europe. So Dr. Fauci said on a podcast with the Journal of the American Medical Association a few days ago that raised a red flag in his mind. Probably shouldn't have said raised a red flag. He probably should have said that was an intriguing finding. Let's find out what that means. So there were early recommendations to avoid ACE inhibitors and ARBs. That's since been relaxed in the societal guidelines for cardiology, diabetes, and kidney patients is continue those drugs if you've been taking them for the treatment of your cardiac, kidney, or diabetic diseases. And in fact, there's an investigational trial looking at angiotensin reversing receptor blocking agents to try to see if it makes a difference in the time course of the illness, and they're looking to see if it's beneficial. So I think all of that information is interesting and right now remains uncertain and confusing. So I think people need to stay on their medications for the treatment of hypertension related, if they have underlying heart disease, diabetes, and kidney disease. But I think as time goes along, there'll be these small case studies of a whole host of drugs that'll come up in the press. Most of them will raise this great interest, and then they'll fade away as studies show that they're probably not beneficial or may be harmful.
I would like to take to discuss a little bit what all that means for the healthcare providers in the field. Yes, there is a shortage of N95 masks. If you go to all your usual medical suppliers and then resource to Amazon or other things, buying the N95, which is used for construction even, then they all say, you know, there is delayed availability. We'll put you on the list and let you know when that is available. So we have few N95 masks, and in the office, we're using it sparingly. And usually it's for example, if a patient needs a test and needs to have the PCR test, then obviously you have to use it because they are suspicious. But then and the isolation gowns, the PPE, which is personal protection equipment, that is also, you cannot order those anymore. So we've been using the dentist gowns and other type of isolation gowns for those. But then, you know, of course, that's less than optimal. Is shortage going to be alleviated? The president and the government says they will have the military release some of the stockpiles, but then I don't know when that be effective. And when there's announcement of a lot more tests and 1.5 million tests, in Orange County, we have 2,000 of the public health. Public health is holding on to 1,000 of them, and another 1,000 is made available to the clinics. Thanks goodness we have those private suppliers who have been allowed to manufacture those private tests. But still, there is no way anybody has enough for the supplies. Again, I want to emphasize that, for example, when you're talking about having quick tests, which are mainly antibody tests, as the previous speakers mentioned, in in South Korea, they made the decision very early on to go for any type of quick test. And they use that extensively. It was helpful for them because it gave them a direction as to who should be quarantined and who should be tracked. And they coupled it with a very advanced, sophisticated cell phone tracker of people who are positive, where they go back, et cetera, et cetera. So then so that is why they made that decision, and the numbers of positive went up really, really fast. But again, so Dr. Weiss, if you could talk about further about, for Jared, what does that mean? Because if it's less, the gold standard that we stick to is a PCR test. And then there is a recent one which was just approved. I don't know when it will be made available, but I know that the companies require you to purchase the machine which processes it. So I don't know if that's really feasible or very practical for those of us in private practice.
I think.
Sorry, Marv, go ahead.
No, I was going to say I'm going to defer to you in those comments.
Well, the issue of testing, as I mentioned, is complicated because asymptomatic people will test negative often, even if they are infected. So there is no reason to be doing the test to prove that a person is not infected unless they have symptoms. If they have symptoms in the setting of a large epidemic, they should assume that they're infected. And testing doesn't really offer any further information. Now, let me just clarify. The testing that is currently available in the United States is not an antibody test. Antibody tests are almost always useful only for epidemiology and to identify people who had been infected and are supposedly immune. There's no rapid antibody test available at the present time. The rapid test that's been just released is a test that does not require advanced laboratory handling, and it's manufactured by Cepheid, and it's part of their reverse transcriptase PCR testing of RNA. And a person is either collect sputum or a nasal swab or an oral swab, and this is placed in a small tube that is supplied by the manufacturer, which is then transferred to a packet that is inserted into their machine, and they will get an answer. This RT-PCR, reverse transcriptase PCR, will give you results in about 45 minutes. Now, again, there's no reason for a routine outpatient lab, or office to be offering this test. It is expensive to have the machine, and they have all sorts of different sizes of the machine. The largest one, I think, handles 1,000 specimens at a time. Unless you're in a situation where you are early phase of the epidemic and you want to see how many of your people are infected. In West Virginia, for example, they found that 10% in a hospital setting were infected, and they didn't know that before. That's critically important information. But once you know that there's community spread of the coronavirus, then there's little information to be gained about routinely testing everybody. So it's sort of like toilet paper, that people are rushing because this is the news is out and about, but it doesn't offer any further information on what they should do.
Very clear. Thank you. So I had one physician in the community, Dr. Namquyen, who contributes that he got 2 tests from LabCorp for his office. And in our office, we got 10. So they controlled it. Only 2 tests are given to each physician. So the future of testing is not very bright unless government gets involved into doing massive drive-in. But again, like you said, Jared, we have to have a proper perspective of the situation. And like you said, in a situation, a pandemic like this, anybody who has symptoms is has to be considered like being suspicious of having it. I'd like to make some comment regarding children. I wouldn't be what I am unless we talk about children. So Quynh, would you show again the slides on the fatalities? We have been very blessed in this situation with the COVID-19, is that from the onset, there's that mysterious reason why the children are spared. So there has been 0 instances in which children under the age of 9 died. There's a couple of instances, and I am told that there's about 4 more of children who are 2 have died, and there are a few more who are in very severe critical conditions, mainly infants and children who are at risk. The one child who is a teenager, 14 years old, who died, has also had some associated morbidities as well, like severe asthma and lung problems. So it is a mystery at this point why children are spared. It is thought that they gather a number of respiratory infection. Of course, by the time they're in daycare, they have multiple ones and have some levels of resistance to all the coronaviruses. And of course, as a pediatrician, I hope that this extends also to those who take care of them. But again, so this is one less thing that we have to worry about unless we get into the situation as the multiple phase of the diseases in which you get the most fragile first, the high risk and the elderly, and then it will go younger and younger. But again, so we have a role to play in all this. So any additional comment, Jared and Marvin?
Well, I have one comment about this table of mortality, which I think that is probably quite old. I think that the death rates reported over 50, when further evaluated, in fact, there was recently an article in Nature Medicine that looked like that modified the cascading worsening of death in the decade 6th, 7th, and 8th decades of life. Doesn't quite look as severe as this now in further reflection of data knowing about recovery rates. I sent that article to Quynh, probably it's a letter in Nature Medicine that came out a few days ago. Jared probably saw that as well. So I just don't want people to get too alarmed by the 30% death rate over 60. It's especially you, Quynh. We're all over 60, so.
All 3 of us are in that high risk category.
Marv,
that's why we're doing a webinar instead.
That's a totally appropriate comment.
Yeah.
We should be very careful about mortality rates because it totally depends on what population you're actually using as your example. In the general population, if you look at everything, it's a very, very low death rate. It's, 1% or maybe even less. But in specific populations, people who come into the hospital or people who come into intensive care units, or in certain social situations where if you're in an area where hospitals have run out of ventilators, such as in northern Italy, then the death rate is going to be much higher. So it depends not only on the factor of age, but on what setting you're in, what country you're in, what city you're in, and what the capabilities are.
And great. So it looks like Dr. Nathan Lay has a question. He raised his hand. Dr. Lay, I just unmuted you, so feel free to ask your question.
Okay, so, there's been a lot of discussion as to how long this virus can live in the environment of an infected or potentially infected patient or person. So can you comment on how long do the aerosolized virus can live in the air? And how long do the droplet containing virus that can live on the surface?
Good question. We have at least 2 studies that show that this virus in particular survives for about 24 hours on cardboard and on copper surfaces, and 48 hours on plastic and other metal such as stainless steel, and in artificial nebulization. In other words, artificially suspending it in air, it survives for at least 3 hours or more. It's inactivated by ultraviolet light and by all the different usual disinfectants that we mentioned. So it's pretty easily environmentally controlled, but you got to clean surfaces off in the immediate context of a sick patient.
Jared, can you comment for people who are listening, because this is a concern that many people have, is how do they handle their mail? How do they handle their groceries?
The money.
How do they handle their vegetables?
Well, again, a very good question. And I think I'm sort of fatalistic about changing anybody's pattern of fear, because I think it's a fear response that you don't want to touch anything that someone else has touched, even if it can't transmit the infection. And in those situations, there's virtually zero possibility of transmission. I suppose if someone spits on or sneezes on the mail just as they hand it to you, that would be not good. But outside of that kind of transmission, it's not transmitted by food. It's not transmitted by other fomites, which is the technical term of an inanimate object that transmits infection. And just like normal washing vegetables would prevent. It's much more dangerous, in fact, to worry about E. coli and salmonella in food than it would be for this virus. Viruses tend not to be transmitted in those fashions.
Jared, I have another question, since you've got the expert's hat on today, and this comes up in the community. What about my pets?
Again, a great question, and it's most frequent that people give their pets more illnesses than they receive from them. There's been one documented case in Hong Kong of a dog that apparently had a mildly positive polymerase chain reaction for the coronavirus. This was not associated with any illness that was reported and this isn't a medical report, this was a news report, it was on the internet. So we don't know the details. Dogs can get influenza, but usually not human influenza A or B. They can spread influenza among themselves and share with some other animals. As far as the coronavirus, only if you have a pet bat, I think, should you be concerned. And I wouldn't recommend keeping pet bats for a variety of
Anyway.
reasons. So no, I wouldn't worry about the animal connection here.
Well, Jared, there is apparently, and again, it's not in the medically reviewed. There is apparently one dog who was COVID-19 positive and died, and then passed it on to another one in the same household. But then, so that's what we hear. But all these, I don't know whether the dog which died had any other coexisting morbidities. Did it have any other illnesses, whatever, cancer, lung disease, heart disease, what's not. But anyway, so I agree with I never thought bats were that cute anyway.
Yeah, I haven't seen that report about the dog death, but in any case.
Yes, and just as a heads up, we will be sending all of these slides and images to everybody who's participated. They'll also be available online for you to reference. There's a lot of information. And Stephanie Gordon asked if you could share the links to those studies and how long, coronavirus can survive on surfaces. So we'll be providing all of those links to verified sources. And then, let's see, Dr. Quynh Kieu, do you want to present more? We're about 1 hour and 1 hour and 10 minutes into our webinar.
Quynh, would you, as a public health person, would you please reemphasize from the standpoint of public health, what are the measures which are recommended at this point?
Yes, okay. So I am going to share a couple of things, but I understand the anxiety. There's a lot of information. So I'm going to share a little infographic from back in the day, and this is Typhoid Mary. One question we did receive was about asymptomatic carriers, and Typhoid Mary is a perfect case study of that. She was an asymptomatic carrier of typhoid fever back in the day, and she got a lot of people sick. She wasn't washing her hands, and after she passed away, after 3 decades in quarantine, they confirmed she had typhoid, but she's asymptomatic. That relates a lot to what we're going through now, where there's a lot of questions about when it's like what tests are available, can I get tested, what should I do? And there's a lot of information, but the biggest picture is that right now we're doing the best we can to collect data. These the numbers are changing as we speak. So from a non-specialist, non-healthcare perspective, the best thing you can do is to keep washing your hands. That is the best way, with soap, by the way. That's the best way to get rid of any pathogen on your hands. You want to wash your hands for about 20 seconds at least under water. And when you turn off the faucet, don't turn it, use your, your palm of your hand, use the back of your hand or your elbow. And if you want, there are 2 songs that I've been using to wash my hands are, singing the ABCs, or washing, or Happy Birthday. There's plenty of other songs on the internet. And the other aspect too is really about social distancing. So here's a really helpful infographic, and it's about really why social distancing is important right now. So as you can see in the red, like the idea is that this horizontal line is really about the healthcare system capacity, is how many patients can a hospital take before it becomes overwhelmed. Those variables include, how many staff are available, what equipment they have, how many tests, masks, and the curve really represents like how many people are sick at a given place in time. Now, the reason why social distancing is important is because it slows down the progression of the disease. Now, if everybody gets sick, like in the first scenario where the curve, exceeds the capacity of a hospital, that's when pandemics get out of hand. That's when they're completely, everything kind of goes straight into chaos. We saw that with the Ebola outbreak in 2015 in West African countries where the healthcare systems were overwhelmed by cases. We saw that in Italy, and there's also a lot of questions about, well, why were there so many case mortalities in Italy versus in Korea? There's a lot of different variables, but a big function of it too is a lot, like Italy did not implement social distancing earlier on. So for everybody who is curious about that and frustrated and understandably frustrated by it, it is the best thing you can do at the moment to make sure that our healthcare workers who are on the front lines aren't overwhelmed. And one thing, and again, there's an article that went out recently of spring breakers in Miami who said, if I get coronavirus, I get it. That's true. However, the issue is that that is the opposite of social distancing, and you're not helping mitigate the spread of the disease. So there's a idea of like, well, if I don't have the symptoms, then I can't pass it on. That's not true. That's not entirely true. It's a similar case of typhoid Mary, where she's asymptomatic, but she did pass it on to other people. The biggest thing is that, you know, you might have it, you may not have it, but someone who has it touched your sleeve or something, and you just happen to hug grandma, and that's a way to, it's just a possibility, it's one of many possibilities of spreading disease. So again, social distancing is to eliminate a lot of variables where you can accidentally transmit the disease. And this is not to cause panic. This is actually just a helpful mindset that I would recommend everybody adopting in face of a pandemic. It's instead of approaching this pandemic as, I don't want to get the disease, a really helpful way is to imagine that you're sick and you're not trying to give it to someone else. You may not be sick, but once you change your mindset of like, similar to like if you have the flu, you know, I don't want to get anyone sick, it's the same thing. You take the same measures in place that you would take to be considerate to family members or friends. I'm going to also answer a couple questions that we received during registration. Okay. So one of the biggest things too is communicating to people why this is why you need to do social distancing. There's definitely a variety of communication issues going on in terms of how should I be scared of, being blasé about the disease, and then also being perhaps a bit too cautious about everything. And I would say the best way to communicate the severity of disease is that right now our hospital systems are not overwhelmed, and we want to keep it that way, because it is very difficult to communicate something, to say something like, oh, social distancing, you can't go to public gatherings, and then conceptually it's very abstract. It's like, well, how does this benefit me in a way? I would just keep emphasizing that you don't want to overwhelm healthcare workers. Please do not go into offices and steal masks and equipment from medical offices. There have been reports about that. Please do not do that. The medical and healthcare workers need that much more than you, because they are the front line responders. So that's the kind of behavior that is not helpful during a pandemic. What you could do instead is to make sure that during this time, under stay-at-home orders or self-quarantine, to keep your social circle very small. And by small, I would say ideally, from a pragmatic standpoint, really only keep. I mean, again, anybody step in to if I'm wrong, but I remember keeping it very minimum. I personally keeping it to less than 5 people, just because those are 5 people I see maybe regularly. Honestly, it's been more like 2 for the past 3 weeks. I keep in touch over FaceTime, text messages, anything. But just because for me, I did work in LA before the outbreak or the pandemic was officially declared, and I was taking public transit. Now, for myself, I know the incubation period for the disease is about 2 weeks. And even though I'm a young, healthy adult, the way I see it, I'm like, I don't want to accidentally be an asymptomatic carrier and to give it to somebody by accident. And then in terms of communicating to Vietnamese parents who don't understand what's going on or may need some resources, we will again be providing resources on the website in terms of, you know, what is helpful in Vietnamese and English. And there is also, there is a lot of, I guess, in a lot of ways, depending on if you were born here or if you're living here or in Vietnam, there may be some distrust of the general information coming out of Vietnam in terms of what statistics are reported. So I would recommend, in terms of helpful resources, to really refer to the WHO website. They have lifetime data that is collected from nations that are reporting it. And again, like, the biggest limitation about these numbers is what is being reported. But it is a very helpful snapshot of incidence rates. Dr. Weiss sent me a very helpful document, so I'm going to share that right now, about what's happening in Vietnam. Let me just zoom in. Okay, great. So as of March 17th, 2020, so there's a total of 66 infection cases. 16 have recovered, 50 are being cured. And that is what's happening in Vietnam for those who are curious. But you can also see all these numbers again on the WHO website, which provides lifetime updates of tracking. And then, let me see. And lastly, I'm going to just make sure I'm answering everybody's questions. So yeah, and there's also, it's really important to keep your mental health in check. There's a lot of news. It's very overwhelming. There is a lot, you know, again, it's with social distancing, the other issue comes up is social isolation, especially for people who are older. And, you know, in my case, I haven't been able to see my parents for a while just because they are over 60, and I don't want to risk that just because I, you know, took public transit in LA. And that can be very hard. My recommendation is, you know, every day to at least do something that you know is a guaranteed. It could be a little routine, such as making your bed, making breakfast, making something that is consistent every day, and focusing on things that you do have control over as opposed to things you don't have control over. For instance, we do not have control over how the government responds per se. You know, we do not have control over how many tests are available, what equipment is available. Is there going to be toilet paper in the shopping, in the supermarket? Which is very frustrating. But things that you do have control over is, like, you know, how much sleep do you choose to have? What do you choose to engage with during the day? It could be reading a book, watching a movie, playing video games. And so, yeah, that's important. I also want to note about the increase in hate-centered attacks against Asian and Asian Americans in the United States and around the world. There's a lot of reported increased hate attacks. So understandably, that also does not help with the general anxiety of this pandemic. So I would say we will be sharing a resource of, like, if you encounter an attack based on a hate crime, if you are the victim of a hate crime, you can report it. It's a free reporting center. So just in terms of that, again, you can't control how people react around you. I would just say to remain as calm as possible, to de-escalate the situation. And if you do feel very unsafe, to, you know, make sure that you can get yourself to a safe place. Some people have suggested recording it on your phone if possible. I would just say, like, do everything you can to de-escalate the situation, and also to remember that you have every right to go about your life This virus is not tied to any race, so it is race neutral. It affects everybody. That was a question in the registration about what to do. But yeah, I'll be sending that resource, or that resource will be available for reporting any hate crimes. And then
I would like to mention some of the things that we at Project Vietnam are initiating and ask for your help and contribution to that. The number one is, besides getting all the PowerPoints and all the references here, and Jared, there's been a very a marked interest about getting the reference on ultraviolet effect regarding helping against a virus and other methods of desanitizing. Also, we are concerned about the parents now who have to deal with these special need kids. A regular kid is hard enough when you have more than one, let alone the special need who is an attention deficit, for example. And I'm dealing with my grandson who is, and then in other more severe conduct disorders, or a child who has autism spectrum, who is very used to a very structure and functions adequately, or is used to function in a very structured environment. And we will have upcoming conversations with you all regarding suggestions about doing that. I'm talking to one of our volunteers to help us lead a meditation group through Zoom, and that's something that we can all do. And let's discover, try to use our enforced inactivity, or to use it to do something new. For example, in my neighborhood, people have been walking the dogs. They don't cross the street to say hi to each other anymore, but they say hi from across the street, which is more than the 6 feet recommended. So you can still do that. And then I have people on the lawn who spread the chairs and then talk outside, which is better than being in a confined environment. And then there are other things that, for example, worshiping online is a new experience for me. And I found it to be very enlightening, and it has been very good. So, and I get to discover worshiping in different settings. Like I was looking at a service at the National Cathedral, for example, and I was enjoying all the beautiful setting of the church, and so on. So you could try and travel, if not in effect, travel through the web. So these are other things that can be done. But we would like to come back and be able to present along with our all the resources and all our volunteers. Please contribute things that you have which are helpful to people, and this is something that we would like to keep on going. Some of our volunteers have suggested that they would like to collect some of the N95 masks and make it available to some of us who are experiencing severe shortage of the N95. Anything, a lot of different things can be done. If you're forced to stay at home, please sort through your wardrobe and find out things that you can give. There is in Orange County recently, a few months ago, one of the organizations which works to help the homeless get a job, to give them a professional wardrobe for interviews, etc. We could collect to give to them. And there are myriads of different opportunities that we can participate in the community.
Thank you. And I also wanted to follow up Dr. Lay's question about, home safe, speak about home safe for over 65-year-old people, and how it's important to keep going outside, getting regular exercise and sunlight with social distancing. Many of our seniors are staying indoor and getting very depressed and anxious. So yeah, that is one of the issues of social distancing. About, yes, it is helpful for mitigating the spread of the disease. It's not so great for mental health. So this is one of those things that, if possible, if you're able to go outside, if you have a backyard, and that is definitely a great way to go outside and do some basic exercises. There are great free videos on YouTube that you can follow if, and a big if, there is a walking pathway that is safe, and that you can maintain a safe social distance from other people who may be walking around, and it's still very possible to walk around and get sunlight and maintain social distancing. Some people have gotten very creative. I've seen people where a senior created kind of like a ring around him that was 6 feet, or, basically you could not get near him 6 feet. So it was kind of like a ring. He looked like Jupiter. Some people have gotten even more creative and bought stuff like a T-Rex, costume that operates sort of like not a hazmat suit, but kind of. But yeah, it's still very possible. But the most important thing is it's a very fine balance of making sure you're safe, and also your physical and mental health well-being are safe. And again, just to, it's very tempting to shake someone's hand and to give a hug, but as of now, it's not advisable because of the many risks involved. Let me see. Oh, are people able to sew masks and help? Yes, actually. So if you are great at sewing and it's something you like to do, people are doing that as we speak. There is, again, that resource will be provided about how you can, help contribute by sewing. So for anybody who really loves sewing and they find themselves now indoors, that's something that you can do if you really want to lend your time and to really help out with the cause. And then just wanted to make sure.
So we will, Quynh, let's try and compile a list of the questions.
Yes.
And if we haven't specifically answered them, then we will ask our panelists to address them.
Yes. And then the last thing too, I wanted a major question that was raised during the registration was, how do I communicate with my parents about coronavirus, and to make sure that I'm communicating appropriately. There is a lot of data that depending on your generation in the Vietnamese community, you are less likely to go to the doctor for a variety of reasons, either because of language, health insurance, and other, or even like, I'm fine, I'll write it out. I would communicate the same way that Dr. Weiss and Dr. Spotkov mentioned earlier, which is to say, if they want a test and they're not showing any signs or symptoms, they'll be like, even if you get the test right now, it will not be helpful. If they are showing the signs and symptoms, then that is when you should absolutely go to your primary care physician and say, they're showing the signs and symptoms, and what are my test options? But the most important thing is to communicate prevention about, they ask, why do I have to stay inside? I'm young. And again, it's like, the frustration is valid of, I'm young, or I feel fine. Why do I have to do this? And it's like, why are you telling me what to do? The most important thing is like, you want to communicate that you're doing it because you love and care about them. And they know that, but it's also always helpful during a pandemic to emphasize that, and to really say like, and if it helps to be like, this is bigger than them, it's for the Vietnamese community and for the larger community that we're a part of, to make sure that we're taking care of everybody. And if there are any other, the one thing I want to end with is that this pandemic is unprecedented. I mean, it was very predicted and also unprecedented. We are very well connected by the internet, so that's another interesting variable. I would like to emphasize that instead of thinking about only yourself, which is a valid thing, it's like, you want to make sure you have plenty of food, that you are, keeping social distancing, keeping your mental health in check. This is a really great time to also check in on your neighbors who may not be able to go to the grocery store like you do. This includes elderly patients who are not as fast as somebody who's in their 20s or 30s, or even somebody who is in their 20s or 30s, but is immunocompromised. They may have lupus, they may have asthma, they may be whatever reason having some kind of their immune system is compromised, this is a really great time to check in on them and say like, hey, can I help you buy groceries? Can I help you buy supplies? Because they may not be able to or have the time to go out and wait in lines, you know, to be let in singularly into a grocery store. So I really encourage everybody to reach out, not physically, but, you know, to within appropriate, you know, means to maintain social distancing, but also text, call, anything. And that's what I want to end it with, that we will get through this together.
Essentially, like my priest was saying, very appropriate. We are alone, but we are apart, but not alone. So we are a community, whether it is Orange County, whether it's Project Vietnam, it's the neighborhood, etc. So we here really are offering you because we would like to support everyone and all our volunteers and people in our circle in these circumstances. Privately, I never thought we would go through this. I thought leaving Vietnam and being forced to immigrate would be the greatest challenge in my entire life. But no, until this came, I thought so, but I was wrong. So anyway, we will go through this together. And again, I'm very, very much confident in the fact that the world wars did not end until the United States got hit. Pearl Harbor happened, and then it turned around the war. It turned around completely towards victory. But then in this instance, not through government, but through the fact that the commitment of all of us to devote our resources and the industries and all the foundations and all our scientists towards let's do it. So again, we will be sending you and compiling all the references and sending it to you. Just make sure we have your email so that we can do that. And then you will see a lot more. And then maybe we will work out on having a place like a little forum where we can post the questions and the answers to it. And then also you will be seeing more activities from us here at Project Vietnam. So,
okay, I think this is a great time to end the webinar because we've been going for a little over an hour and a half. But if anybody who registered, who participated, this webinar recording will be available. You'll receive it with all the resources that Dr. Quynh Kieu mentioned. And if you have any kind of questions, please feel free to send them to communications@projectvietnam.org. And I really wanted to thank everybody, Dr. Spotkov, Dr. Weiss, Dr. Quynh Kieu, for participating. This is a great forum, and I hope everyone has a great rest of their day.
And again, because of it's in our name, I would like to reemphasize that if the questions are in Vietnamese, we're happy to answer them and to provide the information in Vietnamese as well.
Mm-hmm.
Thank you all.
Okay.
And thank you, Dr. Spotkov and Weiss. No, Dr. Kraft had a little problem, couldn't join us. And thank you all.
Okay, great.
Bye-bye.
Bye-bye.
Bye.